Okay, so I'll start with introductions. Can everyone hear me?
Yep.
Yeah. Okay, so my name is Leo Bibas. I'm a cardiologist and intensivist based out of Montreal. On behalf of our committee based of Dr. Michael Goldfarb, Aaron Rayner Hartley, and Andrew Fagan, thank you all for joining us today. We're excited to discuss a paper. Dr. Kapoor, 30 minutes ago, sent us a message saying that he had to scrub into an emergency case, but he kindly got his colleague and first author of the paper, Dr. Garan, to join us, who's here today. So we're happy and thank you for joining us. So I think we've all felt that the past few years that the PAC pendulum is swinging back. So before starting presenting our paper, I'll present our speakers. So first of all, Dr. Ian Pitcher will be presenting the article over 10 minutes. So Dr. Ian Pitcher grew up in Western Canada in Calgary and Vancouver. He completed medical school at UBC, internal medicine in Ottawa, and is now in the second year of his cardiology residency at UBC. He's planning to pursue further training in critical care. And Dr. Garan, I just quickly looked at this, so Dr. Garan, please add anything. He's the first author of the paper, and he works at Beth Israel in Boston. He's a cardiologist trained in advanced heart failure, and we're happy to have him. So without further ado, Ian, please go ahead and present us the paper. Let me know if you could share your screen. If not, I'll make you host so that you could do it.
Does that work for everybody?
Yeah.
Perfect. All right, so thanks so much for the introduction and the opportunity to speak today. As you all know, the paper we're talking about today is complete hemodynamic profiling with pulmonary artery catheters and cardiogenic shock is associated with lower in-hospital mortality. It was published in November in JACC of last year. And so just a quick little background before we jump into the article. So pulmonary artery catheters were commonly used in ICUs in the 80s and 90s until several studies have showed no benefit when using them routinely in critically ill patients. So I think there's been a multitude of studies. Some of the larger randomized trials initially was the PAC-MAN trial, looking at general ICU patients and using PA catheters. FACT was looking at patients with ARDS and was also looking at the fluid management strategy. And then lastly, ESCAPE was looking at patients with decompensated heart failure. But in a lot of these trials, and particularly in ESCAPE as well, cardiogenic shock patients have been excluded or they're underrepresented. And arguably, this is the population that might benefit most from obtaining hemodynamic parameters. So more recently, an increase in the availability and use of short-term mechanical support devices has led to a renewed interest in use of PACs in guiding both management and device selection. And they're useful for a few different reasons. And firstly, in confirmation of cardiogenic shock, also in identifying whether it's LV, RV, or BIV failure, and identifying the severity of cardiogenic shock. And I think sometimes we're a bit surprised by the numbers when we put in the catheters. And all this is in the hope that early identification and appropriate device selection will prevent patients from going down into the cardiogenic shock spiral. So getting back to this paper, the Cardiogenic Shock Working Group is an academic group that began collecting registry data starting in 2016. It's collected from 16 academic and community sites across the United States, and each site has to have quite a high number of patients, so a minimum of 100 cardiogenic shock patients per year. In this study, the first 8 of those 16 were selected to be used. The goal of the study was to investigate the association of pulmonary artery catheters, assessment on in-hospital outcomes when used prior to initiation of mechanical support. I think an important definition for cardiogenic shock is it can vary a little bit between studies. In this paper, cardiogenic shock was defined as a sustained episode of systolic blood pressure less than 90 for at least 30 minutes, or use of vasoactive agents and or a cardiac index of less than 2.2 in the absence of hypovolemia, or if the patient required the use of mechanical support. So the study population, there were 1,400 patients over 18 years old with cardiogenic shock from any cause. And they had a few different groupings that they were looking at. The first grouping of the patients was the etiology of shock. And they had 3 different categories. It was acute myocardial infarction, acute decompensated heart failure, or other, which was kind of the grab bag of what's left over, but that included etiologies such as post-cardiotomy or myocarditis. And then they also looked at patients by the stages of cardiogenic shock, and they defined these as the SCAI shock stages. Although they didn't have the data available when looking back through the patients, what they did is they categorized them into the shock stages by the number of devices that they required and the number of drugs. And you can see that in the middle figure here. And so, of course, more devices and more drugs means sicker patient, and so their categories were formed from those. And then you can see the distribution within the stages to the right here in the pie chart, with majority of patients being in stage D. And of course, stage A isn't included in this population, as it's the at-risk. And then they also looked at classification of PAC usage. And so they split this again into 3 different categories. The first was complete. And for complete, you need to have 5 different hemodynamic parameters measured. You need to have a right atrial pressure, a pulmonary artery systolic pressure, pulmonary artery diastolic pressure, pulmonary capillary wedge, and pulmonary artery oxygen saturation. Incomplete was lacking any of the 5 variables, and then none was, of course, if you didn't have a pulmonary artery catheter or it was inserted after initiation of mechanical support. And lastly, they looked at the hemodynamic assessment. And so this was looking at the vital sign parameters and what their association to outcomes was. And the way they did this is they looked at the overall study cohort, and then within each parameter, they broke that down into quartiles. And then they also looked at the different cohorts based on the etiology of cardiogenic shock as well. And so this is table 1, a bit of a big table, and there's actually on the next slide an extension of it. A couple things I wanted to point out from it. Majority of the patients were males, majority of the patients were white, and on average, the patients were relatively young, with age being approximately 6 years old. As you can see in the medical history up above it, kind of the typical comorbidities we would expect in this population. So this is an extension of table 1 here, and then they include the hemodynamic parameters as well as the echo, and the average ejection fraction was 23% for incomplete and complete, and about 30% for none. You can also see the numbers of patients in the different categories at the top here, according to the PAC usage. So in the complete assessment, they had almost 600 patients of those 1,400. Incomplete was 550, and then none 260. So this is table 3, and I think there's a few different interesting things to point out from it. So we can see on the y-axis, there's the different groupings. So by the mechanical support treatment, by the shock cause, and by the SCAI stage. And then on the x-axis, again, we have the PAC usage categories. You can see, like we'd mentioned earlier, a majority of patients are SCAI stage D. Majority of the patients were also heart failure as the predominant etiology of their cardiogenic shock. And then within the complete assessment, you see that there was a significant difference in the amount of heart failure compared to MI patients. And this will become important when we look a little bit farther, as they did have different rates of mortality. As you'd expect, majority of these patients were on medical therapy. And I think speaking to how sick the population is, so you can see at the top there, only 15% of patients did not have mechanical support. And kind of interestingly, actually, majority of those patients had had a complete assessment. And lastly, again, pointing to how sick the patients were, in that there was not an insignificant or a fairly large amount of patients that had multiple mechanical support devices at about 22%. So what they found for overall in-hospital mortality in the different SCAI groups, in B, there's actually 0% mortality, but then it starts to go up fairly quickly. In C, it's 10.6, D at 32%, and then E quite high at 55%. Like I mentioned earlier, the highest rates of in-hospital mortality were those in the acute MI group. So almost 40% in acute MI versus about 25% in both the acute decompensated heart failure and in the other. And so this is the central illustration here. You can see in the pie chart, again, the distribution of patients within the PAC utilization groups. And below that, in the different groupings by association with mortality, you can see there are 3 different groups. There's overall, there's SCAI stage D and SCAI stage E, and the different PAC usage categories. And there was an association with less mortality in the group that had the complete assessment in all 3 of these groupings. And then looking at the forest plot on the right here, so again, split by the different sky stages as well as the overall cohort. And even when adjustments were made for comorbidities, for cause of shock, and for PAC usage per site, there was still a significantly higher odds mortality in patients with no PAC or incomplete compared to those with a full PAC assessment in the overall cohort. Looking at the hemodynamic parameters, these were available for almost 1,300 patients. And when they looked at the different etiologies of cardiogenic shock and they broke them down into the quartiles within the hemodynamic parameters, what they found is that there was a linear relationship in association with mortality with both mean arterial pressure, I think as expected, and then with right atrial pressure, which is interesting. Elevated heart rate was associated with a non-linear mortality relationship. And then pulmonary wedge pressure, cardiac power output, and cardiac index did not impact mortality consistently across the groups. And so this is figure 3 here, which I've kind of just included for reference. I think I've pointed out most of what I wanted to chat about it. And so as far as limitations for the study, I think the authors were quite clear on what their limitations were. It's a retrospective study, and so all the limitations that come along with that. In patients in whom a PAC catheter was inserted after mechanical support, they were categorized as having no PAC. Potentially, this could have been a higher acuity subset with a associated higher mortality. In the incomplete PAC category, the physician still may have had all the data available, but it wasn't documented. And so when they were doing the retrospective chart review and obtaining it, they didn't have it, but it could have been available for the physicians who were there. And then I think importantly at the end is, of course, pulmonary artery catheters just provide data, and this needs to be correctly interpreted and have available treatment options that improve outcomes. And of course, they don't have exactly what the interpretations were based on the data available here. And so that was it. I wanted to be fairly quick, so we had lots of time for discussion since we only have the half hour on the Zoom.
Okay, well, thanks a lot, Ian. That was really great, straight to the point. And it was a great presentation. So now we have Dr. Guran here. Is your microphone unmuted, Dr. Guran?
Yes.
Yes, hey, so thank you so much for joining us. So if anyone has questions, just ask them out loud or write them in the chat. I'll just start with opening question, just to lead with what Ian finished with. So obviously the PAC is not actively treating anyone. We're using that information to guide therapy. In your center or at other centers participating, is there a protocol guiding therapy, or if not, would you say practice is homogeneous? Just give us some insight on what's going on in your centers for this study.
Yeah, that's a sort of a great lead in. I appreciate the question. I appreciate the ability to stand in for Naveen, and as you mentioned, he's actually he got pulled into a shock case. So the shock working group really formed sort of Naveen, actually. This was his initiative in 2016, and the way that it sort of formed, it was a small collection initially of centers that were cardiogenic shock centers, meaning there was an adequate volume, which we wanted to see at least 100 cases a year of cardiogenic shock, and although there's not a uniform algorithm for managing shock across the different sites, each site did have their own sort of internal algorithm, and obviously that's subject to variation, practitioner to practitioner, but that was kind of I think the initial focus was to really find centers that would be able to contribute to this growing real world registry of really all comers with cardiogenic shock, so we could make some important insights. I mean, obviously there have been some randomized trials in this space, but they've in general been very difficult to conduct. And so I think there was a recognition here that we wanted to move away from single center device specific analyses and look more at all comers with shock, recognizing that there's a difference, I think, between the shock from acute myocardial infarction and decompensated heart failure and all the other etiologies that we are collecting. And this initial analysis that we've just looked at was a retrospective analysis. And I think it's important to put that in context and understand, we started collecting before the SCI before the SCI classifications were presented, by a couple of years. And so that staging classification was applied to the cohort to sort of try to get some classification to understand a little bit more kind of the trajectory of the patient. As you highlighted, a lot of the patients do have invasive hemodynamics. There's certainly a focus within this registry to understand the importance of hemodynamics. And as you're saying, there's no therapeutic benefit to the insertion of a PA catheter in and of itself. It's all about how you use the data. And so the first point, I think, to recognize is that the data that was extrapolated from the ESCAPE trial was largely a different patient population than the one that is included in this real-world multi-center registry, where we're really looking at clearly defined shock. I mean, most of the patients were C, D, or E, so it's a pretty sick cohort, and we didn't dictate how centers were using the information. To your point, the completeness of the hemodynamic assessment, I think, speaks a little bit to it's kind of about how you use the data to get the full hemodynamic picture, because the device itself doesn't actually provide any benefit to the patient if it's not used, I think, to its full extent. And the other last point to make, and then I'll stop so others can ask any questions, is the fact that there did seem to be a stronger association between the presence of the PA catheter and improved outcomes the sicker patients got. So really kind of for the patients that you would most want the data, the SCI stage D and stage E, the strength of association seemed to grow, again, with the limitations of a retrospective data set, which I think fits with a lot of clinicians who do think that there's value to having invasive hemodynamic data.
Sorry, Leo, I think you're on mute.
Thank you, Ian. So we just got a few questions in the chat. I got them directly, but you guys could message them to everyone. So would you think that there's value of the PAC in the hemodynamic data it provides, or that the PAC is some sort of yellow leash that keeps the care provider and team more connected to the patient? Do you think it's the data or the fact that we're just more around, or there's, for example, an expert in advanced heart failure that's at the bedside because there's a PAC?
That's a great question. It's a fair one. At the end of the day, this has all the limitations of a retrospective data set. So we don't really know. We don't have granular data to know, the interventions across time and how the different data points from the device itself even drove, changes in therapy. What I can tell you is that we've moved now to a second phase of data collection for this registry, which has now grown to about 20 sites, where we're collecting data points at multiple times throughout the course, and actually trying to get a better sense of how decisions are driven by the data that's derived from the catheter. So we'll have more granularity in terms of impact of the information through time and how that's linked to therapeutic decisions for the patient. So I guess I would say stay tuned. I think we'll have better data to answer that question directly.
Okay. Thanks for that. Another question that came, so a lot of the earlier trials, we said that the earlier trials with PACs did not have, cardiogenic shock exclusively as a population, but one of the signals that we saw is that there was very little benefit, in fact, no benefit in most trial populations, with increased complications, whether they were related to the site or to the swan itself. Or did you see that here?
We did not. I mean, I do think it's important to recognize that these were all centers where by sort of nature of selection, a lot of these centers use the PA catheter pretty commonly in their practice. And so just by virtue of that selection, that has to be, the data and the conclusions have to be interpreted with that potential selection bias. I think certainly, complications are real. And I think, the focus on certainly discontinuing the PA catheter use is a critical one when it's not providing, benefit or, helpful decision to drive decisions around therapy. But again, I think a prospective look at this, which is ongoing, will give us a better snapshot. Again, with the caveat that most of the sites that are going to be included in this tend to use PA catheter more, and that they're obviously with any monitoring device or any procedural therapy, there's going to be probably some correlation between complication rate and frequency of use. But that's an important question.
Thanks. So another question by Dr. Overgaard, which actually is related to one of the questions I want to ask. So one thing I noticed when I read your paper is that you used community and academic centers that had at least 100 patients with cardiogenic shock. So I work in both, and I would say that for even a big community center, at least where I am in Quebec, I don't think we see 100 cardiogenic shocks a year. I think that's a big amount. I think that speaks to the dense, how densely populated maybe cities in the States are compared to Canada. So a lot of our community ICUs kind of let go of the PAC. In fact, if you want to put one in some ICUs, the nurse, you have to get the nurse that's been there for 20 years that's still around to kind of help you. Would you recommend, based on your use and the information, that we should ramp up PAC use and programs for nursing and teaching in centers that maybe don't have MCS backup necessarily there? And should we use it maybe again in all patients with cardiogenic shock, or do you think we should maybe just reserve it for the kind of centers you've seen?
I think one of the benefits of the device is early recognition of deterioration. We know we're getting more and more data in the cardiogenic shock space to recognize that a normotensive patient is not necessarily if there's potential for hemodynamic compromise and evidence of end organ perfusion, normal blood pressure should not be a reassuring thing. And I think that having the device and the information it provides really gives you an early red flag that there could be progression to more and more profound hypoperfusion. And so I think, obviously you want centers to use this when they have a comfort level with it. But I think there's a role for it, at least as, if not a monitoring, continually using it in the ICU, at least the ability to get a snapshot at the very least and a willingness to actually check hemodynamics, for hospitals that have, a cath lab and the capability to do that, so that there can be triage to centers that can provide MCS if the hemodynamics, at least at that snapshot, suggest that's going to be likely, understanding that it is just a snapshot.
In your centers, a patient with acute MI and cardiogenic shock, is the PAC placed, would you say, very early on, like in the cath lab, or is it placed in the ICU?
For AMI shock, it's in the cath lab. For, there's a growing recognition that shock, cardiogenic shock in different disease states, AMI versus decompensated heart failure, looks different in a lot of different ways. And one of those ways is sort of how they come to attention of people who should be involved in that care. So for a decompensated heart failure patient, many times that patient may receive the PA catheter in the ICU. But for AMI related shock, I think that the cath lab is where we tend to use the device up front.
And did your data speak? I mean, I don't know if you have the granularity for this in your data, but in terms of any measurement led to more interventions or any, I feel that's a bit harder, but did you find that in your data?
We didn't. So I think the limitations with this were because it was retrospective, we didn't really have sort of a timeline for each case to go through and say, this piece of information becoming available through the PA catheter at this time led to, this next therapeutic decision. But as I mentioned, in the second version of this registry, which is already launched, we're collecting data through different time points throughout the stay for the patients in the ICU, and we'll focus on escalation and de-escalation of device therapy and how that data drove decisions around those sorts of interventions. So I think we'll get more and more data from this really kind of rapidly growing data set than we presented in this first paper.
Thanks for that. Is there any questions that anyone would like to ask? You could unmute yourself freely.
I had a question, actually. I was just wondering, one of the sort of competing technologies that you see coming up is point of care echo. And you had mentioned early recognition of decompensation as one of the benefits of PA catheter. I was just wondering if you could speak to maybe that's where the PA catheter maintains a role as this early warning system, or if there are other benefits you see versus sort of serial echo that seems becoming more common in many ICUs.
I think that the question about, where are these therapies, when you talk about point of care echo and invasive hemodynamic monitoring with PA catheter, are they, my bias is to say they are complementary, but I think it's a fair question. There's an ongoing randomized trial based in Italy that's looking at early initiation of balloon pump for patients with decompensated heart failure and cardiogenic shock, and they are actually doing a sub study where they're sort of comparing echo and invasive hemodynamic monitoring to really kind of see are those decisions driven by differentially by those two monitoring modalities. I do think that, again, part of this comes down to the different underlying subsets, where the, again, this is somewhat anecdotal, but I think my interpretation of echocardiographic, let's say RV failure in the setting of acute myocardial infarction, I'll be the first to say I'm not an echocardiographer, but I tend to be underwhelmed by the degree of RV dysfunction, with an LV infarct, let's say, whereas the hemodynamics may suggest there's profound transient RV dysfunction. And I think one of the benefits of having the catheter is really early recognition of a biventricular problem as opposed to a univentricular problem, beyond what I think the echocardiographic assessment provides. But that's a fair question. There's certainly a tremendous amount to be gained from echocardiography and serial echo. I think we need data sets like the one that I mentioned that will help us understand, whether they're complementary or whether we are getting adequate data from point of care echo, where we may not need the PA catheter to the same degree.
Thanks for that. So our 30 minutes is up. If anyone has a pressing question, I'm sure we can make time for it. If not, I just want to thank you so much for filling in. We'll catch Dr. Tom. We'll get him back for next time, but I wish him a lot of luck for this case, and it's very fitting that it would fall during this time. So again, I want to thank you all for participating. Thank you, Ian, again for presenting. Thank you, Dr. Grant, for being here. And we'll send out a summary of this. Dr. Fagan's going to work on that, and we'll send that over. And looking forward to the next journal club and the end of this pandemic. So thanks everyone for joining.
If I could add just one last quick comment, and that's as we expand this registry, we want this to be a global registry. So that if there are people who are interested in participating, we would absolutely welcome participation from any sites. So please either reach out to Naveen or to me. Happy to discuss.
Thanks for that. Thanks a lot for joining, everyone. Enjoy the rest of your afternoon or morning, wherever you're logging in from. And thanks again.
Thanks.
Thank you.